Greetings, everyone, and welcome to another edition of Cosmetic Corner. My name is Chris Surek, your moderator, and tonight we are very fortunate to have Dr. Ahmad as our expert discussant. As many of you already know, he is a thought leader and an expert in the field of rhinoplasty surgery. He is a section editor for ASJ and a very well-published author, including 2 major textbooks in rhinoplasty. He also is the program chair for this year's Aesthetic Society National Meeting. We are truly grateful he has taken time to visit with us tonight. How are you, Doc?
I'm great, Chris. Thanks for inviting me to comment on this article.
Well, we're honored to have you. Now, this study reported 7 cases of vascular compromise following filler injection, all of whom had a history of cosmetic rhinoplasty. And it was accompanied by a very nice commentary from Dr. Claudio DeLorenzi, where he pointed out the scientific weaknesses of the study, but then went on to say that clinically he feels that rhinoplasty patients may in fact pose an increased risk for filler-induced necrosis, stating that the cutaneous vascular network often restructures once certain vessels are compromised in rhinoplasty. Secondly, the nose tissue is scarred, and therefore he feels the vessels are more rigidly fixed and maybe less mobile and flexible. And lastly, he postulates that these vessels may in fact be more resistant to enzymatic degradation. So let's dive right in and talk about some components of this article. First of all, can you share with us your initial thoughts and impressions on the study, both design, results, and the take-home points?
Yeah, Chris, I think the most important thing is initially looking at the title of this article, one thinks that this is related to a patient who has had rhinoplasty and then has a subsequent injection of filler into the nose. And I think most people that do nasal surgery and inject fillers would agree that the scarring, the altered anatomy does make injecting a nose that's had surgery more risky for problems such as vascular compromise. Now, this study is really about patients who have had filler injected to the lips or nasolabial fold who had vascular compromise and tissue necrosis in some cases. When they looked back at a 2-year review for patients that they've treated for tissue necrosis or vascular compromise, they found out that 7 patients had a history of rhinoplasty. So this article is really saying that is there an increased risk for vascular compromise if you've had rhinoplasty when you're injecting in areas outside of the nose? Now, I think Dr. DeLorenzi did a very good commentary on this article to point out his thoughts in the area, what he agreed upon, and also some of the scientific weaknesses in methodology. But I think that the article does bring a very important point across that I think, quite frankly, most injectors don't really think about when they're injecting outside of the nose, that nasal surgery can have an impact.
Yeah, most certainly. Now, he mentions in his commentary the discussion about division of the columellar vessels in an open rhinoplasty approach. So the logical question is, if it's a closed rhinoplasty, in theory, do those patients, are they at less risk? What's your thoughts on that?
Well, Chris, as someone who's done a fair amount of secondary rhinoplasty, I think that whether it's open or closed, you can never predict what's been done under the skin. There are instances where closed rhinoplasty has been performed and there's significant alteration in the anatomy and including the cartilage and the soft tissue envelope. So I don't think that the history of closed rhinoplasty is any insurance against altered anatomy.
That's good to know. And you would know that you do a lot of revision rhinoplasty, so that's definitely expert advice there. Tell us a little bit, I know that you do some filler rhinoplasty in your practice. And obviously this is an area that we're cautioned for, just to be certain that, we need to make sure we know our planes. Can you talk to our listeners about how you approach doing filler injection safely in the nose?
So, Chris, I think the nose is a unique area in the face. It's a confluence of the internal and external carotid systems. There's multiple vessels that supplies the nose, especially the nasal tip. And it may be important when you've had surgery there, as this article is postulating. It also plays into the fact that when you've had surgery, injecting into the nose can be quite risky because of altered vascular supply, and it essentially being an area of the face that is a terminal blood supply in some cases. This is one of the areas, along with periorbital injections, where I think that the risk of complications and the potential severity of the complication, requires us to be very diligent as well. So I think when you look at the nose, and a nose that's not been operated on, the anatomy is clearer. The blood supply is just below the skin and the subdermal fat, and it's superficial to the SMAS layer. In addition to that, certain areas of the nose that we commonly inject, like the dorsum, there's more compliance in the tissues. So if you inject in a deeper plane, deep to the SMAS on the perichondrium, you're generally away from the larger blood vessels in the nose, and you're injecting into tissue that's more mobile and compliant to accept the volume. When you inject into the tip, the tissues are more adherent and tighter, and I think putting larger volumes of filler become very difficult and more problematic. Now, if you look at a post-surgical nose, when you inject into the nose, because the quality of the soft tissues changes, in some instances, the soft tissue envelope becomes very non-compliant and rigid. And then you also look at the changes in blood supply. I think, as Dr. DeLorenzi pointed out, in some instances, the columellar artery is divided. Sometimes lateral nasal arteries can be divided. And then the blood supply, especially to the tip, can become very tenuous. Mm-hmm. Now, that's related to necrosis, and I think more commonly necrosis affects the lower half of the nose. We tend to associate vascular complications that affect the eye and vision with the upper half or superior half of the nose because of the connections between the supratrochlear artery and the angular artery and the dorsal nasal arteries. However, I don't think any area of the nose is, I don't think that either of the areas is exclusive to each complication. There have been cases where injection in the inferior half of the nose has led to blindness. There are cases where injection in the radix and superior half of the nose that lead to tissue necrosis. So I think when we're approaching injecting a nose, the most important thing is understanding the anatomy and the depth of the injection, understanding that careful technique with movement of the tip of the needle or cannula with very low flow, low pressure injections with small volumes is very important. And that's probably the principle in any area of the face to reduce the risk of getting product intravascular.
Well, thank you. Excellent answer. Now let me ask you this. What about enclosed rhinoplasty, right? They talk about how we divide our columellar arteries in the open approach. In a closed approach, is there, in theory, maybe less of a problem post-operatively for the filler-induced possible necrosis? What are your thoughts on that?
Well, I don't know necessarily, Chris, because I think as someone who's done a fair amount of secondary rhinoplasty, you just never know what's been done under the skin. Just because the incision hasn't been made across the columella doesn't ensure that the blood supply hasn't been changed dramatically. Mm-hmm. And I think another important thing, that's in regards to injecting filler into the nose. But another important thing is, with this article, is how does post-surgical changes in the nasal vasculature affect the other areas of the face? Is what's happening when a lip or a nasolabial fold is injected and someone's had previous surgery, that potentially the contralateral side isn't enough to ensure blood flow, that flow through from the nose through the columellar artery into the lip is important, or flow across the nose to the contralateral side of the face is important. We just don't know, but this article really shows that, as Dr. DeLorenzi has pointed out, that no area of the face is safe. There's so much variability in facial anatomy, as you know. When you look back at almost every cadaver study in the face that's looked at patterns of arteries, up to 10% of the cadavers that are looked at in any vessel that has paired vessels, it doesn't cross the midline.
Right.
So there's no overlap. And I think that also can contribute to when patients have complications like this, is the variant anatomy.
Well, this was a great discussion. I really enjoyed visiting with you. We appreciate you taking your time. Thank you again.
All right. Thanks, Chris.
All right, everyone. Thanks for joining us. We'll see you next month on Cosmetic Corner. Bye-bye.